Okay, let's give a warm welcome to Dr. Mary Strek.
Thank you. Thank you. Can you all hear me? Okay, great. All right, thank you so much for inviting me to come. I am giving you an update on scleroderma and the lung, and I was personally last here about 3 years ago, and there have been some advances and some new information that I'd like to share with you. First, I'm going to provide a bit of an overview of the lung and how it can be affected by autoimmune or connective tissue diseases, and then talk primarily focused on scleroderma, and then we'll move on to management and treatment where some of the new information comes. So the importance of talking about the lung in scleroderma is in part because the complications of scleroderma do involve the lung often, and those complications are frequently underrecognized until later in the disease course. The lung complications may not track with the other complications, the ones that Dr. Swice talked to you about today, the peripheral manifestations in the tissues and the joints and the skin. The lung complications can definitely, in a subset of patients, impair quality of life. They may masquerade initially as idiopathic lung disease. So I have a number of patients that came to see me with their lung disease diagnosed, but their scleroderma not. And the treatment is different if you have scleroderma lung disease versus idiopathic lung disease. And that's because the scleroderma, when it presents in the lung, may primarily initially present just with the lung disease, and so that's very tricky then to figure out that the scleroderma is present. Over time, the other manifestations of scleroderma may become apparent, or it may remain that the lung is primarily the manifestation of scleroderma. And very importantly, there are treatments which are better in terms of their effectiveness if they're started early. So here is an overview. I use this a lot for the medical students and the trainees when I'm talking to them about how the different connective tissue diseases, some of the other ones that affect the lung include rheumatoid arthritis, lupus, mixed connective tissue disease, autoimmune myositis, but of course today we're focused on scleroderma. Each of those autoimmune diseases have typical presentations, with rheumatoid arthritis primarily involving the joints, and the autoimmune myositis primarily involving the muscles. And as we know, scleroderma can involve all of the body, but with the skin manifestations being the hallmark of that disease. Each of these autoimmune diseases has specific blood markers or antibodies that give some clue in some patients that that disease is present. In addition, you'll see that I have included compartments of the lung. So the lung begins with the airways and then involves the lung tissue, the ILD, this interstitial lung disease that we're going to talk more about. It can also involve the vessels, the vasculature, and the lining of the lung, the pleura. And so as you see here, scleroderma is characterized by these anti-nuclear antibodies. In some patients, particularly with lung disease, this SCL70 antibody may be present. Airway disease, like we'd see in asthma or emphysema, is much less common in scleroderma than in some of the other connective tissue diseases that affect the lung. There are a couple types of the lung parenchyma or interstitial lung disease, NSIP, UIP. We'll talk more about those terms in a minute. In addition, pulmonary hypertension or high blood pressure in the vessels of the lungs may occur in scleroderma. However, the lining of the lung, the pleura, pleuritis, pleurisy, is much less common than with the other autoimmune diseases. So with that big picture overview, we're now going to focus more on scleroderma itself. Here is the current classification criteria that many rheumatologists would use to make a diagnosis of scleroderma. Now, these criteria can be used in the clinic, but were formulated for research studies, and so you may or may not fit into the category of having a score of 9 or higher, where a doctor would be very confident, especially for a research study, that you had scleroderma. Now you'll see that if you have skin thickening of your fingers of both hands that comes proximal to the metacarpal phalangeal, so this joint here, you have a 9, and everybody would agree you have scleroderma. The patients I see often have more subtle manifestations, so don't have that skin thickening that comes that far up. And so we're looking for other clues, like the puffy digits, which I'm going to show you in a minute. History of fingertip ulcers, telangiectasias, which are little blood vessels that are enhanced on some of the lips and the skin. This pulmonary hypertension or lung disease, lung tissue disease, interstitial lung disease, the Raynaud's that I know Dr. Swice talked about, and then these autoantibodies. And so this is a photograph of the hand of one of my patients who gave me permission to use it, who I initially saw some years ago, and she came to me being told she had idiopathic parenchymal interstitial lung tissue disease. It turned out I took one look at her hands and heard she had Raynaud's, and those hands are not entirely normal. You see a little bit of the discoloration that sometimes happens with the Raynaud's, and they're also puffier. Now, they don't have frank thickening of the skin the way some patients with scleroderma do, and I think this is why it was missed when she was seen elsewhere. But when I investigated further and did a blood test, she had that SCL70 antibody, and so it became clear that her lung disease was due to scleroderma and was not idiopathic. In fact, there's a term, a fancy term, that has been coined in the literature called systemic sclerosis or scleroderma sine. That means without scleroderma. So patients who have subtle manifestations of scleroderma such that you really have to be a detective to determine that they're present, yet have organs that are involved from scleroderma, like the interstitial lung disease or the pulmonary hypertension. And this shows a test that Dr. Swice might do in the rheumatology clinic, looking at the capillaries of the fingers where they meet the nail bed with a little drop of oil. And if those capillaries, those red vessels that are there, let's see if I can get my pointer, or I'll use the, how's that, the mouse. If you see these blood vessels, there should be a lot of them. And there's these whole areas where they're missing. There's dropout, there's vascular dysregulation and destruction, and the ones that are there are dilated and tortuous. And having this would go a long way towards making a diagnosis of scleroderma with these telangiectasias seen in the nail bed being a real clue. So it is important for primary care doctors, for rheumatologists, and for pulmonary doctors to be on the lookout for signs of scleroderma in any patient who seems to have pulmonary disease that's unexplained, especially if it involves the pulmonary vessels, pulmonary hypertension, or the lung tissue, the interstitial lung disease. Something I've become more and more aware of and have been spending a lot more time talking with my patients about is the fact that sometimes these autoimmune diseases and these lung diseases that I care for may be due to some exposure. And for some patients, that exposure may have come in their workplace or may have come in the home. And if the exposure is ongoing, it becomes particularly important to recognize. I care for men with scleroderma, which is much less common than women having scleroderma. And of the men that I care for with scleroderma who have lung disease, a handful clearly have been in occupations that likely has contributed to, if not caused, their scleroderma. And so this is information from a study that was published in 2014 looking for environmental exposures that might contribute to the development of scleroderma. And they compared 100 subjects with scleroderma compared to 300 controls who were matched as carefully as they could for age and sex, so men matched to men, women matched to men. And there was an increased risk of scleroderma in patients exposed to silica, paint thinner, aromatic solvents, ketones, and welding fumes. And as you might expect, the exposures differed by gender, with men being more represented in occupations that involve sandblasting, granite cutting, bricklaying, cement work, and sheet metal use. Women were more likely to be office workers, perhaps exposed to some of the fumes and things from printing machines and other exposures that might occur in the office place. And then a much smaller study coming from Italy. This involved primarily men, in fact I think it was exclusively men, who had silica exposure as stone cutters in quarries in Italy who developed autoimmune disease. And there were, of the 40 cases of the men who developed silicosis from the stone cutting, 23% had autoimmune disease, which if you think about it, compared to a general population of people, 23% don't have autoimmune disease. And so this was a 7-fold increase, really suggesting that the work exposure likely had some contribution in these men to the development of their autoimmune disease. And as you see, 3 had scleroderma, and these are the very significant digital ulcers that was present in one of the patients. All of these patients had such significant lung disease that they required lung transplantation. So I do a very detailed history with my patients to talk about ongoing exposures that might be present in the workplace and in the home in order to see if we can identify anything that might be relevant in the home. Mold exposure, bird antigens in particular seem to be triggers for patients to develop this type of lung disease, and perhaps there may be an overlap in patients with scleroderma. So now we're going to focus on the lung manifestations of scleroderma, particularly on that interstitial. So interstitial, that's the area of the lung between the tiny airways and the tiny blood vessels that exchange oxygen. It's the lung tissue at the deepest level. And then we're also going to talk about how the esophagus, the big feeding tube, can be dysfunctional and sometimes perhaps allow acid and particulate matter to get into the lungs and cause injury. Here are the rest of the major causes of lung disease in patients with scleroderma, with pulmonary hypertension, important and something that I'll spend just a little bit of time on. As I mentioned, airway disease is uncommon, but I do have a small percentage of patients who have an asthma-like syndrome to their scleroderma, and in those patients we would use inhaled medicines. I mentioned pleurisy. Uncommon, but something we remain vigilant for is the development of lung cancer or scar cancer in patients with scleroderma lung disease. And then again, very uncommon, but can happen, is the inability of the chest wall to move normally and limit the patient's ability to breathe normally, especially with exercise, due to scleroderma thickening the skin of the chest wall. Now, scleroderma, when it involves the lungs, tends to have primary types. There can be overlap, but patients who have primarily the lung tissue, the interstitial lung disease, tend to be separate from the patients that have pulmonary hypertension. Of course, if the interstitial lung disease advances and involves a lot of the lung tissue, pulmonary hypertension can develop there as well. And what you'll notice is that if you have the lung tissue involvement, your pulmonary function tests are going to be abnormal, and your CT scan is going to show lung tissue parenchymal interstitial lung disease. With pulmonary hypertension, it's the echocardiogram that we rely on to show us the changes, and to be definitive about the pulmonary hypertension being present, a catheterization of the right heart needs to occur. The antibodies tend to differ, with this SCL70, this blood antibody, being positive in a good percent of patients who have interstitial lung disease, whereas the anti-centromere antibody tends to be positive in patients with pulmonary hypertension. So these are blood tests that most patients with scleroderma should have at least once during the course of their disease. Now, of the patients who succumb to scleroderma, the cause of death is in 35% is due to the interstitial lung disease and 30% due to pulmonary hypertension. The good news is that the patients with interstitial lung disease due to scleroderma compared to idiopathic interstitial lung disease have a better survival and a better prognosis, and I do think we're making headway with therapy. Patients who have pulmonary hypertension that is idiopathic tend to do a little better than patients with scleroderma-related pulmonary hypertension, although here too there are new agents that can help with therapy and improve patients' outcomes. So a little bit more focus on the parenchymal interstitial lung disease. We are looking on exam to hear those crackling sounds that sound like hair rubbing together, that you can diagnose the interstitial lung disease by. Of course, this involves the patient being listened to by a physician who's really paying attention, making sure the shirt and all clothing has been completely removed, and that the room is very quiet. And I do find patients who tell me that I'm the first person who ever heard their crackles, but it's clear that the crackles have been present. And so I think this is a missed opportunity, and part of my mission when I talk to primary care physicians and trainees about being very careful and meticulous when examining a patient to listen for those crackling sounds. Sometimes patients will have exaggerated scooped fingernails called clubbing, which is another sign of this interstitial lung disease, and obviously the Raynaud's phenomenon, which often you'll be telling the physician about. I mentioned the anti-SCL70 antibody, which is seen in about a third of patients with interstitial lung disease from scleroderma. Pulmonary function tests are very important, and I'm going to argue should be done in every patient with scleroderma at least once, and probably in most patients followed over time. If the interstitial lung disease is involving the lung in a significant way, the total lung capacity, all the air in the lungs, that measure will be reduced, as will the forced vital capacity, which is the amount of air people blow out when they do the blowing test as part of the pulmonary function test. And then there's a measure called the DLCO, or diffusing capacity, that measures the intactness of the lung tissue to exchange oxygen. And that will be reduced if you have the interstitial lung disease or the pulmonary hypertension. Now, the CT scan becomes very important because the pulmonary function tests can be abnormal in both pulmonary hypertension and interstitial lung disease. The CT scan is going to show us the changes of the interstitial lung disease and will allow us to say whether we see the less fibrotic or more scarring fibrotic type of interstitial lung disease that can happen with scleroderma. The good news is that the less fibrotic, the nonspecific interstitial pneumonia, NSIP, this is not an infectious, this is an inflammatory type of pneumonia or pneumonitis, is the most common type of interstitial lung disease we see on the CT scan in patients with scleroderma. And that is why this is more treatable than patients who tend with the idiopathic, meaning we can't find out why you have your interstitial lung disease type, that is more often scarring. This gives a picture of a CT scan in somebody with the less fibrotic type, and this is looking at the lung tissue. We're looking at the lungs. This is the back. This is the front, and the patient is lying on their back, and we're looking up from the feet. And here is the left lung and the right lung. It should all look like this here with the black air-filled spaces and these tiny blood vessels. But you see these extra white lines, which are the scarring, and then this extra white here, which is the inflammation that occurs in patients who have this nonspecific interstitial pneumonitis that can affect the lung in scleroderma. This is a picture of a lung biopsy, which we hardly ever do anymore in a patient with scleroderma because we know from the CT scan what we'll likely find. And this shows the thickening of the lung tissue and the scarring that can occur with this NSIP. This is a CT scan that shows a more inflammatory type of nonspecific interstitial pneumonia with these increased white compared to the normal dark of a patient with scleroderma lung disease. Here you see that thickening, but you also see increased blue cells, increased lymphocytes and plasma cells. And those are the cells that tend to melt away when we use anti-inflammatory and immune suppressant therapy in patients with scleroderma lung disease. So to the extent that a patient has more of this inflammation in their lung, they're going to get a better response to the therapy as compared to those who have more scarring as a part of their interstitial lung disease. The good news is that while scleroderma, when it affects the lung, can progress to severe interstitial lung disease, that is the minority of patients. So for most patients, for about 80 to 85% of patients, the interstitial lung disease is going to be milder. If it's going to progress, in many but not all patients, it may be rapidly progressive in the first 2 to 5 years, which is when we really need to be focused on whether this interstitial lung disease is present and whether it's progressing. And so the CT scan and the breathing test become very important in terms of us diagnosing and following this type of lung disease. In a larger percentage of patients, there is a gradual decline in lung function over time or stable disease. And so we also are interested in this gradual decline, although if it's very slow and patients in their 60s or 70s, it's probably not going to cause as much problem as if that gradual decline starts when somebody's in their 30s or 40s, because we have a lot more years ahead in which we want to preserve lung function. So in these patients, if they're younger, we too may be talking to them about starting some of the therapies I'm going to mention. And so, unfortunately, the interstitial lung disease may affect survival, but that is in the minority of patients, and I do think for many patients, the therapies we have to offer are starting to make a real difference. So we have to make a decision once we've diagnosed the interstitial lung disease on whom to treat. Because if you have this interstitial lung disease, but it's going to be stable for years and years and years, then giving you medicine that affects your immune system is potentially subjecting you to the risk of harm and unnecessary therapy. And so we don't know for certain in an individual patient the best course, but we do have some ideas from population data of large numbers of patients. Most experts in scleroderma, rheumatologists and pulmonologists, would say that every patient with scleroderma should have a CT and a breathing test at least once, if not over time. If those are both normal, that is really good news. And then we would recommend yearly pulmonary function tests. Now, if every year, year after year, the lung function remains normal, we might then back off to every couple years or maybe every 3 to 5 years, but that's only once we've demonstrated that the lung function is remaining very stable. The majority of patients are going to have at least a little bit of abnormality on the CT, because about 75% of patients with scleroderma have a little bit of lung tissue, interstitial lung disease on CT scan. However, if that disease is limited and the pulmonary function tests are only minorly affected, in the beginning we're going to follow the breathing test very often, but if they're stable, then again, after every year or 2 to 5 years, we may really stretch out the evaluation with the breathing tests. However, if it looks like the lung function is declining or the patient has extensive lung disease, we really do need to be talking with patients about therapy. This is a patient that I continue to follow. I first saw this patient in '99. There are very subtle If you remember that other CT I showed you, this is much milder. There are some increased white markings along the edges and internally, but they're very mild. And this patient had relatively normal lung function, no decrement in their ability to exercise, no oxygen requirement. And so we chose, especially back in '99, when our understanding of what therapies we had to offer was pretty limited and more toxic, to follow. Now in 2003, there was a little bit more scarring, but the lung function remained stable. And the patient chose, actually, of their own accord, not to return for a number of years. That patient has subsequently returned, and the CT scan now, 2018, shows some, in my mind, more significant progression. But the lung function, while it has declined, is only minimally declined, and the patient can still swim, doesn't need oxygen. I have made a tentative suggestion, because the patient is still, in my mind, relatively youthful, for some gentle immunosuppressive therapy, but the patient has chosen to continue off therapy. And that may, in their case, be the right decision. I think we don't ever know for sure in an individual patient. And so there are patients who do have very mild progression over time, but this patient has had now almost 20 years of really continued good health, and is still very, very fit, and so for the time being has decided to remain off therapy. What we don't want to happen is a CT like this, and this is a patient with very advanced interstitial lung disease from scleroderma. And I hope I never see a CT like this again, because I think with early screening, with regular monitoring, and with the starting of therapy early, that we can prevent CTs from involving the CTs that show this really diffuse involvement with the interstitial lung disease. And so I'm going to turn to management and treatment. Here are a list of the current medications that are used for the treatment of scleroderma. Some have more evidence than others, and the ones I've highlighted are the ones that I believe the data really supports their use, as well as my clinical experience. And those are the ones I'm going to focus on, although I am going to mention stem cell transplant, because that's something that comes up in conversation with patients, and is certainly something patients find when they search the internet. So finally, in the mid-2000s, seems like ancient history now, actually, there was the first well-done study of therapy in scleroderma lung. This occurred because finally the National Institutes of Health decided it would support a study that combined rheumatologists and pulmonologists who were academic experts in the field in a funded national multi-center well-done study to look at whether there was a treatment for this interstitial lung disease in scleroderma. Part of the issue is that the funding for national studies come from separate institutes of health. There's a lung institute and there's a rheumatology institute. And the two don't really talk, and their funding lines don't overlap. And that, I think, has really hindered our understanding and our ability to treat patients with a disease that overlaps those two specialties and those two funding institutes. The good news is that there have now been two studies. The first was published in the mid-2000s and compared cyclophosphamide, a drug I hope never to have to use in the future, versus placebo, because that dummy pill, because that's all there was at the time. And what this study showed in patients who had scleroderma and shortness of breath, along with abnormal lung function, quite abnormal, vital capacities down to 45%, diffusing capacities down to 30%, normal being 80%, with some evidence on CT for scarring, but also this ground glass, which is a sign. It was the last CT I showed you that is more inflammatory, sign that maybe there'll be some response. This very potent immunosuppressant, cyclophosphamide, was given for a year, because after a year, most of us would not want to continue to give it to patients due to its risk of causing leukemia, bladder cancer, etc., over time. And so the second year, patients were followed off therapy, and what we looked for was improvement in vital capacity. The results are that they were able to randomize 158 patients out of 267 that were screened. Now, if you have heart disease, your blood pressure medicine that you might be taking has been tested in hundreds of thousands of patients. If you have high cholesterol, your cholesterol medicine that you might be taking has been tested in hundreds of thousands of patients. This is where we're at, and I'm telling you, this is one of the best studies that's been done. But look at how few patients we have. That's partly because this is a disease that affects much less patients, and partly, as I said, because of funding issues and the ability to recruit patients. So in the end, there were 54 patients who got the cyclophosphamide and 55 who got the dummy pill who completed the study. There was a change in vital capacity at 2 months of 2.5% difference. Now that's small. But as my colleague who does lung transplants, or ran our lung transplant program at University of Chicago for many years, Dr. Garrity, has told me, if we can keep patients' lung function stable, or even a little bit of improvement over time, they aren't going to need to see him to talk about a lung transplant. So this is a small difference, but it was a real difference, and I think a meaningful difference. Unfortunately, there were a lot of side effects in the patients on this medicine. Blood in the urine, which is a marker and a concern for bladder cancer down the road, low white count, anemia, pneumonias, and 3 cancers developed early on, with these 54 patients being at risk long term for cancer down the road. So here this just shows the difference in the vital capacity baseline, and then 12 months later there was an improvement in this shortness of breath score, in their quality of life, and in their skin thickness. So there really did seem to be a signal for change across the board in patients who got the cyclophosphamide. The problem was, when they were assessed at 2 years, the vital capacity had gone back to where it was. And so while the medicine seemed to be effective, it came at the cost of significant side effects, and because most of us felt that you couldn't continue this medicine for a second year, patients ended up back where they started from at the end of the second year. So many of us had been using this medicine called mycophenolate Mofetil, or CellCept, a gentle immune suppressant that most, but not all patients tolerate quite well, that had been used, or has been used, and continues to be used in organ transplantation. It has been a real advance. It has allowed patients with kidney and liver and lung transplants to do better, live longer. And so we started to use it to gently suppress the immune system in patients with scleroderma lung disease. Again, not everybody, but many patients tolerate it well. We aim for a target dose of at least 1,000 milligrams twice a day. Some patients do get nausea, some patients do get diarrhea, some patients do get infection, so not everybody can take it. But it does have lower rate of side effects compared to the cyclophosphamide or even the azathioprine Imuran that some patients take. We do need to monitor. When we first started using it, it was expensive. I need to update this slide. The good news is we can now get it off-label at Costco for $25, $30 a month for most patients. And a big issue for women who are still of childbearing potential is if you become pregnant, there is a high risk of fetal anomalies. So we must ensure that our patients use birth control if they're of childbearing potential. So the group of rheumatologists, mostly with a few lung doctors, got together, and the National Institute of Health sponsored a follow-up to that scleroderma study, which was just published a few years ago, Scleroderma 2, looking at that potent but toxic cyclophosphamide compared to the better tolerated, less toxic mycophenolate. And the plan was 12 months of cyclophosphamide versus 2 years of mycophenolate at a full dose. Not everybody can tolerate this dose, 1,500 milligrams twice a day. Patients had to have milder scleroderma, so couldn't have had scleroderma for more than 7 years. And although they could, in those 7 years, have had some significant lung impairment. Again, there needed to be some evidence that there could be some reversibility with this ground glass on CT. And the primary endpoint was change in vital capacity at 2 years. Now, I'm going to tell you a little more about the study, but I just want to cut to the chase. It wasn't powered, meaning there weren't enough patients that could be enrolled to look at whether patients survived better. However, so this endpoint was not statistically significant, meaning the statisticians, when they did their fancy math, couldn't prove beyond a shadow of a doubt a survival benefit. But I'm going to tell you, if I was a patient, I'd rather be in this group, meaning your probability of survival at 24 months is much higher, at least visually, if you took mycophenolate, Mofetil, CellCept, than the cyclophosphamide. So sometimes the statistics can't be powerful enough because it's not truly a difference. And sometimes we just don't have enough patients, and I think that was the case here who were enrolled. But I'll tell you visually, I think this is a real difference. And so in my mind, I'd really want to be in this group and not in this group. And in fact, the data did continue to support that. Again, look at the small numbers. 73% completed two years in the study. A year of cyclophosphamide, a year being followed. 69 patients got all 2 years of the mycophenolate. Were enrolled. 53 patients were actually able to complete getting therapy. You see that a number of patients had to stop therapy, but higher numbers in the cyclophosphamide group. And both had a change in their vital capacity. Unlike the earlier scleroderma study, where at 2 years, those who had gotten only 1 year of cyclophosphamide, the vital capacity went back to normal. In this group that got a year of cyclophosphamide, nothing for the second year, looked like there continued to be an improvement in the vital capacity in that group. What was more remarkable, however, was that there was no change in the diffusing capacity in the mycophenolate group, while the diffusing capacity declined in the cyclophosphamide group. So a real sense that patients on mycophenolate did equally well in terms of vital capacity, better in terms of diffusing capacity, and much better. You'll see 30 patients had low white counts, 4 had low platelet counts, whereas only 4 patients overall had significant side effects from the mycophenolate. So this is clearly, in my mind, the group that you would want to be in. Now, sure. Oh, I don't think so. The target group was dose was the same.
But that one is 1,500 milligrams.
Yeah.
And the previous one was 1,000.
No, it was 1,500. This target dose is just the minimum effective dose to take. This is a general slide here. Sorry, I didn't. I didn't. In Scleroderma 1, there was no mycophenolate. Right? They just got cyclophosphamide. Yeah, at 2 milligrams per kilo per day. So in this Scleroderma 2, they got cyclophosphamide at the same dose as in the previous study, 2 milligrams per kilo per day, and the mycophenolate was 1,500. Yeah. So that slide is confusing. That's just my general approach to the use of mycophenolate, and I don't think below 1,000 milligrams twice a day that the drug is that efficacious. And in fact, I would argue that many of us can't or don't get our patients up to this 1,500 milligrams twice a day. So then to extrapolate that you'll get the same benefit, it's hard to know. And an issue. Not everybody is going to tolerate this dose. My rheumatologist, Dr. Curran, whom I practice with at University of Chicago and have a joint rheumatology pulmonary clinic with, I practice with all the rheumatologists there. They're wonderful. But the two of us have noted that Caucasian patients often don't tolerate this dose, whereas African Americans in general, seem to hypermetabolize mycophenolate and are better able to tolerate this dose. And that is a limitation if we want to try and attempt to achieve the same effect that was seen in this study. So thank you and I'm happy to take questions at any point if there's anything that's not clear. So for patients who have more severe disease, can't tolerate mycophenolate, the mycophenolate isn't effective enough for both the lung and the skin, there is another therapy that I think is a good option, theoretically more potent, theoretically more long-lasting, which good and bad in some respects, and that is Rituximab, which is an IV therapy that is given generally every 6 months. And it can potentially have some good effect. So this was a study looking at 64 patients with skin and lung involvement from scleroderma and compared the cyclophosphamide, that powerful medicine, to Rituximab, I think an equally powerful but better tolerated medicine. And what they saw, again, look at the small numbers of patients that are able to complete these studies, 30 patients in each group. The vital capacity improved in the Rituximab, that's my shorthand for Rituximab group, while in cyclophosphamide, at least in this study, it declined a little bit, and there was a statistically significant difference in the group that got the Rituximab in terms of the vital capacity being better. The change in the vital capacity actually improved. So not only were the two groups different in terms of their lung function at the end, but patients who got Rituximab had an improvement in their vital capacity where it was unchanged in those who got the cyclophosphamide. The skin score fell. That's better. You have less skin thickening on Rituxan, while it was unchanged in the patients on cyclophosphamide. And this has been seen over and over again. Nobody disputes this. You're going to get more side effects with cyclophosphamide. And so the conclusion was Rituximab was more efficacious and better tolerated. Now, this is a therapy I have used a lot in patients with non-scleroderma but other autoimmune interstitial lung disease where it's rapidly progressive. And again, the scleroderma in ILD, interstitial lung disease, tends, in the majority of patients, not to be rapidly progressive. So I think we don't tend to reach for this therapy as often, and so hard to know in whom we should be using it. But I think we're going to be contemplating using it and using it in more patients than we currently are. Now, the last therapy I want to talk about is stem cell transplant, which is a big deal. We don't do it at our institution, but at Northwestern, they have been doing it and have contributed to some of the literature. And the thinking is, if you're going to give somebody cyclophosphamide with all of its attendant side effects, but there's some sense that in some patients over time that effect wanes, why not just reboot the immune system? And for a stem cell transplant, you're going to get cyclophosphamide in order to wipe out the bone marrow, and then you get your stem cells back in order to regenerate a bone marrow that hopefully is in a different milieu and is going to behave in a different fashion than it did previously. And so this is a randomized study, and I just show you that patients in both groups had the same amount of lung involvement, and that's 100%. So that wasn't the only reason that patients had the stem cell transplant. They needed to have really wickedly progressive kind of systemic scleroderma because, as you see, stem cell transplant is associated with death in 3% at 54 months and 6% in 72 months. So these were deaths that were thought to be just due to the therapy alone. And while cyclophosphamide has some serious side effects, nobody was thought to die from a side effect of cyclophosphamide. And so that's a real consideration. And it really, this is for a very, very small subset of patients. However, when you look at overall survival, that's people who are now not going to be dying due to lung disease or kidney disease or cardiac disease from their scleroderma. So that's overall survival. Those who had transplantation did better than those who got cyclophosphamide. So there's a concern because, of course, we've had some patients die from transplantation that didn't die from cyclophosphamide treatment, but overall the survival was better. And so I think there's a very small subset of patients for whom this might be an option. Now, a special word of caution about those stem cell transplants that are done in the community. You can fly to Florida. They've now set up shop in Illinois. They're not paid for by your insurance. They're not regulated by the FDA. In fact, the pulmonology community is working hard to get these people shut down because they are doing nobody any benefit, and they are causing harm and some side effects and deaths. And these are for profit. Your insurance won't pay for it. And they're not doing any kind of research to show that they're doing anything of benefit. It's voodoo medicine, and unfortunately, they're preying on vulnerable patients. And so a stem cell transplant done at an academic center where you actually ablate the immune system does have some benefit, albeit some upfront cost, in terms of a bit of increased mortality. Whereas what's being done in the community at these for-profit centers is just taking some blood out and giving it back to you and pretending like they're doing something of benefit. And in fact, there have been some deaths and some visual impairment from these stem cell transplants. And so a word of caution about that, and my patients do ask me about that. Now, I do think in the future there will be less toxic stem cell therapy and stem cell transplants, but that needs to be done in a rigorous evidence-based fashion so that we can actually prove that we're doing patients a benefit and carefully measuring whether there's any harm that's coming along with that. Now, I will mention the pulmonary fibrosis medications that right now are approved, and I should say that they're approved for idiopathic pulmonary fibrosis, but there is some suggestion that they may have some benefit in patients with scleroderma. So Boehringer has conducted a study of their antifibrotic Nintedanib in patients with scleroderma. And they have just submitted that data to the FDA. So while one can't comment on what the data shows, generally drug companies don't submit data to the FDA if they don't think the data, in their mind at least, was positive, because the FDA, when it looks at negative data, is never going to approve a drug. And so this is undergoing evaluation right now. The trial has completed. We were a participant in the trial, but were unable to enroll any patients, and that was a real disappointment on our part. But that means we're kind of privy to, kind of some of the ongoing assessment, and it is public knowledge that they have submitted an application to the Food and Drug Administration for review. So generally, the FDA has recognized pulmonary fibrosis as a orphan disease in need of fast-track designation, and so generally are reviewing submissions faster than some other disease categories. And so we really hope in the near future we will know whether the FDA has found that study to be of benefit. And if that's the case, it may be that we can attack the scleroderma lung disease not only from the anti-inflammatory side, but from the fibrosis side as well. And I think that's a real cause for optimism. Now, this is in idiopathic pulmonary fibrosis where it's approved for use. So have to be careful. It's a different disease. It's got more scarring, a worse prognosis. But what you do see is that the vital capacity over time falls, but falls much less quickly than patients on placebo in these patients with pulmonary fibrosis that's idiopathic. And so the hope is that this drug will have been of benefit in the trial in scleroderma, and that we will have another agent in the near future to be adding to the mycophenolate, to the rituximab, and to, in the small percentage of patients, a stem cell transplant. There are some adverse effects of the Nintedanib, which include diarrhea, which is also a side effect of mycophenolate. So, of course, that is an issue, but that was a potential issue in the trial, which allowed patients to stay on mycophenolate. And so if there is a signal for benefit without a significant signal for harm, then that means that if the FDA approves it, that the drug was tolerated. And then just to finish up, just a couple minutes on the scleroderma pulmonary hypertension. It may be unrelated to the interstitial lung disease. Patients with Raynaud's, patients who seem to have less skin disease, anti-centromere antibody, these telangiectasias are more at risk for the pulmonary hypertension. Pulmonary function tests, the vital capacity is often normal or at the low end, 80% is low end of normal, and it's a dropout of the capillaries primarily, this diffusing capacity that is often the signal on the breathing test that there's pulmonary hypertension. I shouldn't say often severe, but it can be severe when it occurs. Heart dysfunction is common. The echo is the first test, but it may not be enough, and we may be needing to do more right heart catheterizations in patients who are at risk. And it can be treatment responsive. And so most of us who take care of patients with scleroderma think that everybody needs an echo approximately every year, because unlike the interstitial lung disease, this seems to potentially happen at any time. Often, early, but can occur later as well. And so we should continue to monitor our patients with echocardiograms looking for this pulmonary hypertension. I didn't talk about therapy. There are many, many therapies now for pulmonary hypertension. Most of them have not been tested primarily or alone in scleroderma, but some of the therapies have included patients with scleroderma and pulmonary hypertension. And so there are upwards of 8 to 10 therapies now approved for pulmonary hypertension, many of which would be available to a patient with scleroderma and pulmonary hypertension. So last, a word about reflux. And so this is in general for patients, and here are these tiny little air sacs with their capillaries, and this is the interstitium, the lung tissue that gets affected in scleroderma. We think that gastroesophageal reflux disease, and so what happens is here is your stomach, and if the opening to the esophagus is floppy, as happens in scleroderma, or the esophagus doesn't squeeze normally to keep the food and bile acids that get made down in the stomach, can reflux up into the food pipe and then into the windpipe and then into the lung, causing injury. And so we do think that this might contribute to pulmonary fibrosis. We don't know for sure, but we think it contributes in a subset of patients with idiopathic disease and is more likely to contribute in patients with scleroderma because the esophagus is dysfunctional in the majority of patients. So how do we manage it? Well, if a patient is overweight and it's possible for the patient to lose weight, that can help. We recommend that the bed be elevated by 6 inches. That's enough that it helps, gravity helps keep the stomach acids and the stomach contents in the stomach at night when you're most at risk when you're sleeping. However, 6 inches is usually not enough that you end up on the floor in the morning. We ask that you avoid eating for 2 to 3 hours before lying down, and that's even napping during the day. Where possible, you eliminate foods like caffeine and alcohol, and if you can't eliminate them entirely, then that you try and eliminate them before sleep, before napping. Proton pump inhibitor before the first meal of the day. Now, proton pump inhibitors, the omeprazole, those type of medicines, we do know are associated with some long-term side effects. So we aren't willy-nilly giving these to patients who don't have true reflux. But a patient with scleroderma and reflux probably is going to benefit from being on a proton pump inhibitor. Rarely, we have to use an agent to help the esophagus squeeze, and occasionally there can be a little surgical fix. Have to be careful about doing this in a patient, though, with scleroderma, because if the motility, the muscle function of the esophagus isn't normal, you can tighten the sphincter between the esophagus and the stomach, and then all that happens is the food can't get down into the stomach to be digested. And so this is usually not an option for a patient with reflux and scleroderma. And so just to finish by talking about some of the monitoring, and so our treatments do have some side effects, and I think patients, they can be used more safely if we're careful about monitoring labs, about doing screening for cancer prevention, about trying to prevent infection or serious pneumonias if you're on an immune suppressant. Big believer in vaccination. I've mentioned following lung function, chest imaging, and I would add the echocardiogram, and then we're always monitoring for infection. So in conclusion, scleroderma is a chronic multisystem autoimmune disease. It has a variable clinical course. Most patients will not develop the severe interstitial lung disease that I talked about, but there is milder and subtle disease. And for those patients, we probably should be doing monitoring, especially as our therapies get better and less toxic, and because we want to treat before there's irreversible organ damage. And just finish with a photo of our team, which includes chest radiology, pulmonary pathology, our now new junior rheumatologist, our ILD nurse specialist, clinical research coordinator, and our care team providers. So thank you very much. I'm happy to take any questions.